When a patient presents in your office with a cervical disc herniation, they could have an antalgic lean. It can either be unilateral or bilateral. If it's bilateral, it's a central herniation. If it's unilateral, it would be a lateral herniation. Some present with pain, tingling, numbness down the arm, usually in a dermatomal pattern. They can present with weakness, hypertonic muscles, decreased range of motion. That's it. The anatomy of that area, you have obviously the disc. There's the nucleus pulposus and the annulus fibrosus. There are ligaments on both sides holding it in, the ALL and PLL. There's facet joints up behind it, nerve roots coming out that could be irritated, and the spinal cord, which it could be compressing. The pathomechanics, dehydration will cause the disc space to be decreased, which will cause irritation and a posterior shift. It will cause the IVF sometimes to be smaller, and which irritates the nerve root, and that will cause degeneration. There can be inflammation and compression of the nerve root, or just irritation of the nerve root. Special tests that I would do would probably be, initially, probably not, but I could do x-rays to see a decreased IVF, or MRI to see if the herniation is going into the spinal cord or protruding out. Okay, so the main test I would do is Jackson's compression. So I'd have the patient laterally flex to one side. I'd put a downward force, which is increasing the pressure on the disc and also closing the IVF. And they could have radiating pain down their neck or down their arm. And then I would go to the other side and do the exact same thing, downward force. And if they're having pain on the other side, then it's usually muscle. And then the three other orthos I could do would be like DeJarnine's triad, ask the patient to cough, sneeze, and see if they have any increasing pain with that to rule out space-occupying lesion. I could do Soto Hall to rule out meningeal irritation, or Adson's and Allen's test to rule out any nerve tension. Treatments that I would do for this, I could do, adjustment, mobilization. I would probably start with an activator or something that was less force at the beginning for acute pain. Rest, ice. Once it becomes subacute, I'd probably use heat if there was no inflammation in it, and then rest also. And then you could tape for pain, or do acupuncture or some home care with ice, and instruct the patient to use ice if they have pain.